Welcome to the Academy Podcast, where our mission is to improve lives through education, information, and some cool stories. My name is Dr. Mark Guadagnoli. I'm a professor of neuroscience and neurology and the Senior Associate Dean for Faculty Affairs at the Kerkorian School of Medicine at UNLV. Today, our guest is Dr. Mario Gaspar de Alba. Dr. Gaspar de Alba is a developmental-behavioral pediatrician. He specializes in autism spectrum disorder, and he's also the Associate Dean for Diversity, Equity, and Inclusion, DEI, here at the Kerkorian School of Medicine. On the surface, it may not seem like autism and DEI are related, but through this podcast, you're going to see a very interesting thread that ties these two together. So, Dr. Mario Gaspar de Alba, I'm so excited to have you here as a dear friend, first of all, but then there are some really cool topics that we're going to get into. We're going to talk about autism. We're going to talk about diversity, equity, and inclusion, DEI, both of which are specialties of yours, both of which actually overlap in surprising ways that we're going to talk about, and then a whole host of other things. But we'll start off talking about you. Okay. Your least favorite subject that you like to talk about. But let's talk a little bit about where you're from, how'd you get into medicine, and in your case, it's, I'll let you tell the story, okay? So where you're from originally, something that you and I share in common.
All right. Well, first, thanks for inviting me.
You're welcome.
And we are dear friends, or I wouldn't be here with you. So
we are at least now, right?
Yes, exactly. So I'm from El Paso, Texas. I was born and raised there. So border town. It's been in the news recently. A lot of immigration things going on. But really, I grew up. I'm the oldest of four. My parents both went to college. My dad's from Mexico. My mom was from there, the El Paso area. And just growing up, I always had an idea of what I wanted to do early on. And some of the students have heard me say, but early on, I wanted to be Batman. And when that dream died and I realized my backstory wasn't good, I thought, well, what else is there? And so my pediatrician at the time was really good, a really nice guy. And he would always ask, what do you want to do? He was always, the assumption was I was going to do something. And so we talked over the years, and eventually we got around to medicine. He said, oh, you'd be a great doctor. And that was pretty much all it took. And, I was motivated, and he'd always ask me, how are your grades? How you doing? How's school? I even saw him when I went to college. I'd come back home for vacations, and I'd see him. He was great.
It's amazing, isn't it, how you have this interaction, this twist, this turn on the road that takes you in a different direction. Okay, what is his name?
Lawrence Nicky.
And tell me why you want to be Batman. And I will confess to you, Batman is my favorite superhero because he's human, right?
Exactly.
But he does all these amazing things.
He does all these things.
And he's got the best cars. Yeah.
That's right. Well, so wealthy, right? Fairly good looking, cool cars, great outfits, and smart. And I thought these are all things like I could do that. I thought I could do that.
You could do that. The interesting thing is fairly good looking depends on who's playing Batman, right? But
I grew up in the Adam West years.
Yeah.
So
I jumped through the Adam West years and became Batman fan around the Christian Bale Batman Begins time. Darker, and I think kind of a cool.
Agreed.
But yeah.
Agreed.
Okay, so Batman, at least at that time, didn't work out for you.
Right.
You have a mentor along the way who took an interest in you. Isn't it fascinating, right?
It is.
That he just decides, I'm going to take an interest in this guy.
Yeah.
Right? Because you don't have a family history of medicine, right?
I don't.
And it's interesting because a lot of our students, a lot of physicians have a family history, right? They have a path that's been walked for them. Yeah. And you really didn't have that.
Right.
Okay, so take us a little bit further on.
Sure.
You do well in high school. You decide to go to college. Okay.
So I go to college with the idea that I'm going to go to medical school. And probably second, third year of college, I take the required pre-med class. It's just your classic pre-medical class. 300 people, 7 o'clock on a Friday, to weed out people that really aren't interested in going. And first day, the pre-med advisor teaching the class says, look left, look right. Half of you will not make it into medical school. And I thought, well, that's not great. It's a little intimidating. And I didn't like the guy.
Yeah.
Plain and simple. And so my own personality was such that, well, I'm not going to ask him for any help. I don't need him.
Yeah, you'll show him.
I'll show him. I don't need him. Yeah, so consequently, my circuitous route to medicine, my applications to medical school were 3. I applied to 3 schools in Texas, not knowing that was unusual, that you really ought to apply to many, many more. I didn't get in. So the year after, when I was going to reapply, I was working as a pharmacy technician. And I met some surgeons, some transplant surgeons who had gone to school in Guadalajara in Mexico. And they said, "What are you doing here?" I said, "Well, I'm waiting to reapply. Why don't you check out the school in Guadalajara?" I hadn't thought about it, didn't even know about it. And so I did. And I checked it out. I liked it. I went with the idea that I would start school, reapply in the States. And if I didn't get in, at least I'd already started. Right? Yeah. I hadn't wasted any time. I never reapplied. I really liked it down there. I enjoyed living in Mexico. I enjoyed the school and the things we got to do. And then it did cost me an extra year because I had to do a 5th pathway program in New York before I started residency. But yeah, that was the kind of a circuitous path, but I think it was good for me.
Imagine that the experiences that you had were very different than if you had gone to a U.S. medical school.
It was.
Yeah.
It was.
And then you followed that up with what would be considered more traditional training, right, in the States.
Yeah. So when I applied to, after that, it's called 5th pathway year. After that, I applied to residencies, did a pediatric residency in Albuquerque, at the Children's Hospital. From there, I worked for a couple of years as a general pediatrician. I knew what I wanted to do. I knew I wanted to do a fellowship, but I also had a family, and so I needed to make some money for a little while. So 2 years was about right. Applied to fellowships and then went to developmental-behavioral fellowship in North Carolina at UNC.
And what drove you into the field of autism, autism spectrum disorder, right?
So in residency, I had an attending, so all the residents were assigned an advisor. And so my advisor was a general pediatrician, Javier Aceves, super nice guy. And we'd talk about things, and I saw patients at his clinic, and I noticed that his interest was always development. It was always behavioral developmental things. And I started to express to him that I kind of liked that part. And so he said, "Well, why don't you go to a conference? I'll send you to a conference." So he found some scholarship money in the program, sent me to a developmental behavioral conference, and I was hooked. I'm like, this is really interesting.
You know, I'll tell you what's interesting. This has come up twice in this story, and I know it's come up multiple times in your life.
Yeah.
Somebody takes an interest, right? And I don't think it's charity, right? I mean, I think that you earn that interest. There's something that they see in you. But isn't it amazing? Like as you being the person who's the recipient of it, and knowing you, I'm sure you don't say, "Oh yeah, look at me." Of course, you're going to take interest, right? That's opposite of you. But it's amazing, isn't it? Yeah. How that changes a person's life.
Absolutely. And that's and I tell the students, so in my role in DEI, right, a lot of what I do is work in the pipeline programs. And that's why, honestly, because I feel like there are kids who just don't know what they can do, right? And they need somebody to let them know, you can do this. You can totally do this, and you can be successful. And so I feel like I can give a little bit back that way in this position.
It's nice to have the perspective of what a helping hand can do for you, and then be able to pay that back.
Yeah. Oh yeah.
So to speak. Yeah. I think you do it in a lot of, you specifically do it in a lot of ways in addition to the pipeline program as well.
Thanks.
So yeah, you're welcome. So
I will say, let me say that I think in just looking at my own history, the other thing that I think is important in that kind of that relationship where somebody's helping you or takes an interest in you is really your part, right? So who knows if my pre-med advisor would have taken an interest in me? I didn't even give him a chance, right? That was my issue, right? My issue with I don't need you. And that's something else I try to get across. Like, it's okay. Like, it's okay to need help. It's okay to ask for help. And I think sometimes the students that we're really trying to help, first-generation students or students from more difficult backgrounds, I think they're less likely to ask for that help. And so that's kind of, I try to bring that perspective too, that, look, I went through that. Like, I was at a point where I don't need you. I really did, but I said I didn't. And it cost me a little bit.
It's interesting because the way that what you're describing is one of two things that are kind of related. One, I don't need the help is an ego statement, and two, I don't need the help is a defense mechanism.
Yeah,
right.
Absolutely.
And I think both of those things could play a role. And then when you talk about people who don't have a path forged for them, they're more likely to have those ideas, right? Well, screw you if you're not going to help me.
Right. Unfortunately.
But I do think it's really cool that people reached out, and to your point, that you reciprocated by doing a really good job.
Yeah.
And now that you're paying this back all the way through.
Yeah. Hopefully.
So, we talked about, before we started today, we talked about in my mind at least, I see a really clear bridge intersection, I guess, between DEI and autism. We're going to start talking about these separately, but then we're going to add them together in just a minute. But let's talk a little bit about autism from a background perspective, and some of the statistics that are out there, and some of them that are a little bit surprising as well. And I've got a couple in mind, but if you could kind of give us, what are the things people need to know about autism spectrum?
So I think probably the most important thing is that it shows up really early. I mean, you can see it really early. For most kids, you can see it really early, and it shouldn't get passed over because early intervention is the best intervention. It makes the most difference, and so that's critical. People understanding that if you have a child who isn't speaking how they should, or having other social delays, maybe their eye contact's not great, or they're kind of quiet, like, don't skip over those things. Really think about it, because you should recognize those things early. And there should be some concern, at least somebody taking a look that can tell you, oh, no, you're okay, versus just thinking, no, it's fine. This is just their personality. That's really important. The diagnosis, the prevalence of autism has really gone up ever since it's been tracked, over these last 23 years. They've been tracking it, it's been going up steady. And there's theories about why that is, and I don't think anybody really knows. Part of it, I think everybody will agree that part of it is just our better recognition.
Right.
There's more awareness, and so there's more recognition of it. There are other thoughts and research that has looked at factors like aging parents, older parents, premature infants. We have more premature infants who are born younger, who survive and do well. Well, that's another risk factor for autism. So there are things that we see that are definitely increasing the numbers, but I think it's a combination of a lot of things. And so people need to be aware that it's out there, and it's common, and it's not something to be afraid of. It's just something to recognize and try to get help for these kids as soon as possible.
So the diagnosis, there's a lot of aspects of autism that has some degree of controversy around it. Yeah. And in the increased number, right, you hear things like, a couple of decades ago in the U.S., 1 out of 100, and then it was 1 out of 56, and then it was 1 out of 48, and so forth.
Yeah.
Some of that, like you said, is because we've got different ways of seeing it, different diagnosis aspects and so forth. Some of it is maybe because it is actually increasing. Yeah, right. And then the question is, and so that's a maybe, and then some of that is, well, with that maybe, why, if it is true, why is it true? Well, maybe it's because of genetic factors and so forth. And you've got these layers on layers on layers of things we don't really know, which is amazing, right? Because it's not like it's a brand new syndrome, right? It's been around. And for you, because this is your primary work that you do, you obviously you see it every single day, and you've got waiting lists of people, very concerned parents, right? Yeah. I just want to say this real quick, because I think about two different types of parents, if you will, and I've experienced this. I'm sure you have. Type of parent who wants to get their child in to do the diagnosis right away, and they'll do it. And the other type who does not want to get their child in because they don't want the diagnosis. Right. Can you talk a little bit about that?
Yeah, sure. So I think there's a hesitancy in one group because they don't want the diagnosis, because there may be some stigma, or they don't want to feel that loss that may come with that diagnosis, this loss of expectation or what my child might be able to do, and that's totally understandable, right? That's hard. And then the other group who is either very interested in the diagnosis so that they can get additional services, and or just interested in the diagnosis so that they can move forward, right? So you can go, okay, what's next? Like, what can we do to help? I really try to help the parents that come in, that first group that maybe doesn't want to or is afraid and not sure. I think it's because they don't understand.
Yeah.
And so I feel like as a physician, we should be educators, not just because we teach at a school, but educating our patients. And so educating them on this isn't a hopeless situation. I mean, there is something that you can do about it, and you can help. And there's lots of things that are going to help your child move forward from here. And so this isn't the end of your road that you've gotten this diagnosis, but the beginning of your road to, okay, how far can we get? What can we do? And don't be afraid.
And I think that's a really important message, right? It provides you an opportunity going forward.
Yeah.
Instead of, there's no doubt there's fear around it,
For sure.
But understanding that early intervention becomes something that's really valuable, and you're either going to be in Camp 1 or Camp 2 as far as it's a yes or a no,
right?
And so finding that out as early as you can and doing something about it, like you said, can be really helpful.
Absolutely.
So one more question around this, the diagnosis piece.
Yeah.
Males are, I believe, 3.6 times more likely, or at least diagnosed more often.
Correct. Right.
So I'm gonna take a question from Jenny, who had talked about this. How autism presents itself in males may be different than females.
Absolutely.
And so the diagnosis, this 3.6 to 1, may not be entirely accurate once we get a better view of how they present themselves.
Yeah. No, that's a great question and a really important observation, because the criteria that we use for diagnosis, people that work in the field, I've heard often say, these criteria were made for boys, because this is how boys present. Girls don't always present that way. Sometimes they do, right? But sometimes they don't. And a lot of times what you see is that in the criteria, the A criteria, which are the social criteria, girls tend to do better there. They just have more skills. They tend to do better. The eye contact's a little better. The engagement's a little better. And it's not even until they're older where you start to recognize, how they do that is off. It's not quite right. And the way they do it isn't fostering appropriate back and forth engagement, whether it's verbal or otherwise, right? And so it just looks different. And so a lot of times they're diagnosed later, sometimes not at all. As you follow them over time, you may see things like anxiety, right? Because imagine living in a world that you don't fully understand what's happening socially all the time, or you're not sure what people around you are always referring to. That would be anxiety provoking, right? That would be concerning. And so they do end up eventually getting help for something. But I'm afraid a lot of them who don't fit nicely into that criteria get missed early on, and they miss out on that opportunity to really get good help.
Yeah, this brings up two things that I'm thinking about. One is, until recently, the diagnosis of cardiovascular disease between men and women were skewed towards men, right?
Yeah.
Men have more cardiovascular disease and so forth. It's because it presented itself very differently, right? And now all of a sudden, when you see how it presents in women, women have mysteriously caught up, and it's. I think it sounds like it's the same kind of a situation.
Yeah.
The other thing that's interesting in what you just said is I saw this video recently where it was a TED Talk. It was a wonderful TED Talk. A woman was explaining how she is autistic and had hid it for years. And it's just what you said. She had studied watching people on TV, how they, if they got this cue, they responded this way, but it was a little bit out of sync, right? And in her case, they thought she was just shy, and so it's really interesting the diagnosis, the number of people who are diagnosed, the gender disparity, and these kinds of things, and the ethnic disparity,
Yeah.
right? Because there's a study in California where it showed that there's much fewer incidents. It says this incidence of autism among Hispanics.
Yeah. Yeah.
And you're like, hold on.
How?
How is this, right?
Right.
Until you start thinking about why that occurs, which
Yeah.
obviously you know.
Yeah.
It's not at all what was presented.
No.
Yeah.
Correct.
Can you talk a little bit about
Yeah,
that?
no, absolutely. So for years, there's been the reported incidents in children of color not having the same prevalence of autism, and really, if you look at that, it's not really a numbers issue. It's a health equity issue. It's an access to care and an access to evaluation issue. And so, really, the numbers should be the same, and I'm sure they are very close to the same. If these kids could get seen at the same rate, right, and evaluated at the same rate, I think you'd see numbers that were very close. So, yeah, I think that's an artificial difference.
And then, like you said, early intervention becomes so
Right.
important. And so now, if they're not being seen, if they're not having that early intervention, all of a sudden it becomes exactly what you said, a health equity issue, which then brings us to DEI.
Right.
Right.
Yeah.
And so, diversity, equity, and inclusion. You are the associate dean for diversity, equity, and inclusion for the School of Medicine. A lot of what you do is pipeline program and really reaching down to the lower grades, even into junior high. Can you talk about two things there, how you got into it in the first place, and then some of the things that you do in the program?
Yeah, for sure. So I didn't start out thinking that this is something I would be doing. When the medical school first was starting, the founding dean, Barbara Atkinson, random call one day and said, "Hey, can I meet with you?" Yeah, absolutely. Didn't know her. I met with her, and she talked to me about this position and this. The school is starting, and we need somebody to do this work. Would you be willing to do it? And my first question was, "Well, why'd you think of me? How did my name come up?" Well, Dr. Cosgrove, who had been here before when the school was started, her husband had been my attending during residency.
Oh, really? I didn't know that. Jeff.
Fall. And so I had been to their house before for residency get-togethers, and so we had met. And so she brought up my name. So it wasn't because I had any expertise in the area or any expressed interest in the area. But when she told me about it, it got just got my wheels turning. I'm like, well, that would be a neat experience and an opportunity, right? An opportunity to help and to give back. Some of the things we talked about earlier, right? To be able to help kids who think maybe they can't do it or who feel put off by the system, right? That I might be helpful to them because I've lived some of the things. So that got my interest, and I said yes, and I started, and I've been learning ever since.
Yeah, and that's the opportunity to give back, right?
Yeah, for sure.
So now you've got two areas, right, where there's a lot of gray zone in both. On the positive side, lots of places to contribute.
Yeah.
On the negative side, lots of places that need contribution, right?
Correct. Correct.
And so, so let's, if you don't mind, kind of dance between both, because the idea of, so if we take away the title of autism spectrum disorder and we talk about a group of individuals who are disenfranchised.
Yeah. Okay.
Right. And there's some uniquenesses to those individuals who have the disorder.
Yeah.
But disenfranchised individuals and your role in DEI, right? Can you talk about that and how those come together for you?
Sure. It's a hard dance. I think when you think about these two groups, right, a group of marginalized people in healthcare or in health education, and then the group of people that are just marginalized in life, right? I mean, it's similar, right? People, it's a lack of understanding where they come from, right? Maybe what their lived experience is, what they can contribute, because they can. I mean, everybody's contribution is different, and this group of people that I'll call neurodivergent, they're different in the way they think about things. They have things to contribute, right? And their way of thinking about things can be really very illuminating and very interesting because it's very different oftentimes. In the group of students or pipeline students who we try to attract to the school, again, the reason we tried to attract them is because of their lived experiences, their backgrounds, the things that they've done in their lives that can help them be better physicians and help their classmates learn about, through their experiences, how to be better physicians, more empathetic, more compassionate, thinking about things like why my patient isn't actually taking their medication. Well, maybe they don't have a car and the bus didn't come, or any number of reasons. So I see how that both marginalized groups can suffer if we don't generally appreciate what they can contribute.
I think it's important that, a lot of what you're doing is working directly with the marginalized group. So you're talking about, but you're a medical educator too, and so you get to work with those people who are going to be future physicians in educating them about working with.
Yeah.
Right? And I think that it's really cool that you get to contribute on both ends of that.
Yeah. No, it's neat.
So it'll seem like we're going back and forth, but again, I see these overlapping quite a bit. So the genetic aspect of it, right? Of autism.
Yeah.
Just like with everything else, it's a little bit murky about it.
Right.
I read that there were 400 likely autism genes, right? And then you're trying to make sense of the jumble, right? So, this is your background, so I'm not going to step into it. But can you talk to us a little bit about?
Sure. Well, so it's interesting because we know that there's a genetic aspect to autism because the prevalence changes based on the number of first-degree relatives that you have with autism, right? It goes up, and so that certainly it's genetic. The problem has been in isolating genes or groups of genes even that are responsible for that. And so of all the candidate genes, right, you can find changes in those candidate genes in individuals that don't have autism. And you don't find them in all the individuals who have autism. So it's been hard to really nail down, well, what is the genetic component? But honestly, I think that speaks more to what the cause of autism is. Like, where does it really come from? And some of it is genetic, but some of it's something else. And we just haven't figured that out yet, right? The immune system has been implicated at various times and in various ways. Still ongoing research on that, right?
Specifically around inflammation.
Yeah. Inflammation. There's been research on maternal autoantibodies during pregnancy. There's been, treatment tried using intravenous immunoglobulins, right? That have in some cases been helpful, and so there's something there. We just don't know exactly what it is yet. So it's this, and that's why I appreciate the autism puzzle piece as a symbol, because for me it truly is a puzzle. Where do all these things fit together, right? And I think we're looking at autism as one thing when really it's one diagnosis, one group of symptoms. But I think what we're going to find someday is that the causes are many,
right?
And so hopefully we get there, because once you start figuring out where it's coming from, treatment gets narrowed and it can become more effective.
It's interesting because it's a spectrum.
Absolutely.
And so there may be things that contribute at one point of the spectrum, but not at another point.
Right.
And like you said, there's, most things in life are nature and nurture, right? Some interaction between those things.
Yeah.
And so it is a puzzle. I mean, it's an incredibly complex puzzle.
It is.
And so for you as a practitioner in the area, how many individuals do you see roughly in a year for diagnosis?
In a year, probably, around 200.
And I've sat through some of these with you before. It's an extensive process all the way through.
Yeah.
My youngest sister is a special ed teacher, and we were talking about this. She asked about, co-diagnoses, right? ADHD, autism, so forth and so on. And one of the things that was fascinating to me watching was how you were sort of separating out the potential co-diagnosis in these. Talk about that a little bit, how you do that.
So that's tough a lot of times because in the past, before they changed the diagnostic criteria back in 2013, about 10 years ago, you couldn't diagnose ADHD with autism. In that, now we recognize, we'll know that kids with autism will often have those symptoms, right? Because ADHD, again, is a group of symptoms. And so the hard part is figuring out, well, where are those symptoms coming from, right? Is a child not paying attention because their frontal lobe doesn't allow them to pay attention? Their neurons in that frontal lobe aren't firing at the right rate to help them pay attention, or are they just not interested?
Yeah.
Right? So in a child with autism, it could be either or, it could be both.
Right, they're not picking up the social cues that this should be important.
That they should,
for them
right,
to
that
pay
it should be
attention
important, or that everybody else is paying attention. Oh, I should be paying attention, or even it makes my teacher happy when I pay attention.
Yeah.
Right, and so they don't pick up on that. And with ADHD, they're just, they're thinking about 100 other things, but it looks the same. And so a lot of times it's hard to peel that apart. And so fortunately, really, the idea is, okay, well, we know how to treat the autism and we know how to treat ADHD. And even if we don't know where exactly those symptoms are coming from, well, we can try to apply those treatments and see how that works. Where does that get us, right? Because there's so much crossover. And it's the same with anything. It's the same with anxiety symptoms, right? I mean, are they not engaging because they're anxious or shy? Are they not engaging because they don't know how to do it and they're not interested in doing it, right? So it's kind of tough. And the repetitive behaviors, same thing. What does that have to do with obsessive compulsive disorder? Is that a different thing, or is it part of the autism? Again, so much crossover. And for me, it makes it very interesting to see patients. That's what really brought me to the field, that every kid is interesting, right? When I did general pediatrics, it was like, oh, you have an ear infection. Oh, you have diarrhea. Oh, you have a cold. Like, okay.
I've seen this 1,000 times,
right.
yeah.
Yeah. But every kid is so different, and it's really interesting for me. It piques my interest. Maybe it makes my ADHD manageable. I don't know.
So when you start looking at the spectrum and ADHD and anxiety in these areas, it makes sense if you think about from the perspective of the stimulation filter, right? Yeah. That as we're talking, for example, we have a sense of where we should look. We have a sense of what we should listen to. Different stimuli have different weightings for us because either we've learned that or something else. Right. But people with all three of the conditions that you're talking about, they don't have the same refined filter, right? And so if you're hearing everything at the same volume, seeing everything, all stimuli are presented the same way, wow, that's got to be overwhelming.
Hard. Yeah, difficult.
I had a very dear friend in grade school all the way through high school. We're still really good friends. His brother, who's a couple years older than us, had autism. Yeah, I was a kid, right? I had no idea, and this is like 1,000 years ago. Yeah. So I had no idea what this was. And two of the things I remember specifically, one, he was sitting in the back seat with me. My friend and his mom were in the front seat, and he started the repetitive behavior and then just launched forward and bit my friend on the shoulder, which at the time I thought was crazy.
Right.
Now looking at it and the ability to be able to express something that they don't understand in that situation, it makes some sense. Right.
Or even being able to understand why they're feeling that way. Right. That's got to be frustrating.
Right. And like you said, then it makes sense where the anxiety comes from. Then it makes sense where the behavior associated with ADHD comes from, and so forth.
Absolutely.
And just I think we, and this isn't unique to this conversation, but I think we think of the world the way we see the world.
For sure.
Right.
Absolutely.
There's you probably know this quote, Annis Nins, we don't see the world the way it is, we see the world the way we are. Right?
Correct. Yeah.
And so we think, this person just can't make eye contact, or this person. I mean, and I don't think we on purpose think that. I think we default to that.
Yeah,
right?
for sure. It's easiest.
Right.
It's easiest.
Just like we see somebody that's not like us, and we make assumptions about that person, right? That's just the default.
Yeah, and that really comes around to that diversity, equity, inclusion work, right? That one of the reasons we want to have students from different lived experiences, different backgrounds, is so that they can all, as they work with each other, figure out, oh, maybe the world isn't exactly how I see it.
Right.
Maybe I'm seeing it from my own perspective, and I need to look a little bit differently. And the more perspectives that each of us can gain and begin to look at the world, I think the better the picture looks, right? The clearer it is, the more correct it is. And I think for our future physicians, just the better physicians they can be as they start to recognize that the world looks different to other people.
Yeah. I mean, we see this in almost any industry, that when we have a workforce that has different perspectives, they usually yield a better product.
Mm-hmm.
And in medicine, that becomes even more important. Right?
Absolutely.
Because if we only know one way to look at a problem, the old saying, if you only have a hammer, everything looks like a nail,
Absolutely.
right? And so, but yeah, being able to have those, because we have whatever experience we have, right? But if we can learn from the experiences of people around us who are different,
right?
Wow, that's so valuable.
How cool is that?
Yeah.
That's the goal.
So, let's talk a little bit more about the autism side of it. What are some of the things that you see as some of the major roadblocks right now?
Oh, sure. In diagnosis?
Right.
Yeah. So one is the available providers who are trained to do that. I think it's like in my field in developmental pediatrics, there's not a lot of us. There aren't a lot of programs.
There's one, right?
Well, there's one here. Right. Yeah, there's one here. There are other fields. Neuropsychologists, psychologists will do testing and diagnosis, which is great. Pediatricians get some training during residency to be able to diagnose, but a lot of them don't feel comfortable enough with the amount of training they've had to do that. So there's just a lack of people. Unfortunately, the way our insurance system is set up also makes it difficult because oftentimes psychologists and neuropsychologists are kind of even taken out of that diagnostic picture because most insurance companies won't pay for those services, right? That type of testing is mandated through the school districts, right, under the Individuals with Disabilities Education Act. So they say, well, we don't have to pay for that. You can get it through school. So they don't. So unless you can pay for that, then kids don't have access to that. Like I said, in my field, there just aren't a lot, right? In some, again, some aren't available because there might be cash only based on the low reimbursement rates for what I do, which is understandable, right? So you start cutting out people. It's access.
Yeah, if I can just say this, but cash only, then speaking of cutting out, that cuts out a pretty significant portion of the population.
A big portion of the population. Yeah, absolutely. Absolutely. And so you're left with a large group of people fighting for very limited resources, right, in the diagnostic field. And it's not much different in the therapy, right? So you have this big kind of backup in the pipeline of diagnosis, but as you move them through, in the treatment side, and we're getting better, fortunately, in Nevada, at least we've gotten better over the last 10 years that I've been here, there are more options. And so kids do get in faster. But even then, if they come to see me, and I do an evaluation and I do a diagnosis and then they start therapy, chances are at some point the insurance company is going to come back and say they need another evaluation. And sometimes a medical evaluation isn't good enough. What they want is a neuropsychological or psychological evaluation. It seems kind of tough when you need to have this per the insurance company, but we're not going to pay for it.
Yeah, and the people you're dealing with are very young, right? So it's tough to have a psychological evaluation at that point.
So as they get older, that's usually when they start to say, oh, they need this type of evaluation. But again, it's unfortunately, a financial issue, that they don't have access to be able to do that. So it's not an easy system to navigate. Fortunately, one of the things that our state has done really well is many years ago, before I got here, they set up this autism treatment assistance program. So this is a state agency that helps families who are uninsured or underinsured to be able to access services. And that's great, and that's super helpful. It's not an easy program to navigate, but it exists, so we have something. So yeah, it's hard. It's hard for families to get through the whole process, from diagnosis to treatment. It's difficult.
So in Nevada, somebody who, in some way, says, I would like for my child to be diagnosed because I want to find out what's happening.
Sure.
From that point, presuming that they're able to navigate the system in a reasonable way
Yeah.
to the point that they actually start having some type of treatment,
Yeah.
how long is that process?
That's a good research question. I can kind of only tell you from my experience. I would say it's variable, to be honest, but I would say more than a year.
Yeah.
Usually more than a year, sometimes much more than a year, unfortunately.
Yeah. And that's if you can navigate the system.
That's if you can navigate the system.
Right.
Yeah.
It just makes it so difficult. And then, again, going back to the other issue, the second of the issues, then if you are not a native English speaker,
Right.
You're not a citizen, you know all of these things,
Additional obstacles.
you may just quit,
Right.
right?
Right.
Along the way.
Yeah. Sadly.
Yeah.
And it's time. And remember, it's time, right? Because we're talking about early intervention, how important that is. It's lost time, and it's really important time. So, yeah, it's disheartening.
It's, it gets back to the point that you made before, a role that is not taught in medical schools, as far as I know, and that is being a teacher.
Yeah.
As a physician, right?
Yeah.
Being a physician teacher.
Right.
And the role of an educator as a physician is, as a healthcare provider, is incredibly important.
Absolutely.
And yet I don't know that we do a good job in med school.
No, it's a critical part. And it's fortunately, I mean, what I've seen, the trend is that we're doing better. There's more emphasis on that, especially during residency. During residencies, I think residency programs have done better in physicians as educators, really instilling that in their residents. And we've done some in the school, and I think it's getting better because it's so important. And honestly, I see it in my own patient population, right? If the patients are better educated from the very beginning about, say, development, if they know, okay, my child is supposed to do this at this age and this at this age and this other at this age, and if they're not, that's a concern, then those kids are going to come to attention sooner, right? Because they become part of the healthcare team because they've been educated. And that's great. That's how it's supposed to work. And I assume in adult medicine it's the same, right? If a doctor, if my doctor explains to me, oh, this is why you need to take your high blood pressure medication, or this is what you should do when this happens, I'm more part of my own healthcare, right? And my healthcare gets better. So yeah, the educator piece is really important.
Yeah, and then to tie it back to something that you had said before, if in your healthcare training you experience a variety of different perspectives from a variety of different people, it allows you to educate even more.
Right. With more compassion, and more empathy, more understanding of where they might be coming from and why one group may or may not want to do a certain therapy, right? And be able to talk through that instead of be upset that they don't want to listen to what I'm saying.
It's the word empathy is so important here. I mean, and to be clear, I mean, we know each other well enough that I'm not casting stones in any direction. I'm saying this with empathy. My heart goes out to people anyone who has a difficult time navigating the medical system, especially in situations that are stressful, and it's just got to be so difficult. And then you add these other hurdles on top of it. Right. So, yeah, and this is, I think, getting back to some of the ideas before, you reach all the way down into junior high school in the pipeline, because these aren't like one lecture in a med class, right? To do this.
Absolutely. Yeah, so in my own story, right, in my own pediatrician, encouraging me to do that. And then, and I should say, my dad, also said, when I thought I want to be a doctor, absolutely. Like with that, you can do that, right? So I had a lot of support. But in that age, which was around middle school, where somebody, told me, oh, yeah, that's great, you should do that. Like gives you the idea that, oh, that's a possibility, right? So those neurons start to fire. Well, in these kids in our pipeline programs, that's the idea, right? Because again, they probably don't have anybody in healthcare, no physicians in their family. They have probably never thought about it. They may not even go see their primary care doctor regularly. I mean, I was fortunate that I did, and maybe that they don't. Maybe they don't even have one. So their best contact, or maybe their only contact, is with these medical students who go and talk to them in their schools. And hopefully they get the message of, oh, yeah, I could do this. And also start to feel like, oh, this would be really cool. And that can then drive them. Because it's not easy, right? You have to want to do it. And I'm so grateful for the medical students that we have, right, who are willing to go and to do those things with these students, put that time in away from their studies to help these kids, right, to help them through this pipeline program that will hopefully be beneficial for them and their families someday.
I've been consistently impressed with our students, with the diversity that we see in our class, and diversity defined a lot of different ways.
Absolutely.
First generation students, I think routinely we have more female medical students and male medical students, and on and on and on.
Yeah.
And then that they reach into the community. One of the things that you've mentioned, Barbara Atkinson, earlier, one of the things that she really made sure of when she started the school was this idea of reaching into the community, right, and serving the underserved. And it's, we've now been through a few different deans, but it's one of the things that I love about the program is it's always been consistent.
Absolutely. Because we know that that's really long term. That's what's going to help our community, right? Helping these kids come through, the kids in our own community, come through, be educated, stay, right, and provide help in our community. We know that doctors who have come from underserved communities are more likely to serve those communities, right? Because it's hard work, but they're more likely to do it, especially if there's a language issue, right? They're just more likely to do it. So our classes that we've admitted, and I think it speaks to our admissions process, really what we value, is students who they're not just interested in practicing medicine in its narrow sense of taking care of patients. They're really interested in helping people, right? And so they do these things. So they go out to the community and they help these students in middle school and in high school. Those are the kind of students we're looking for, right? Because that's who we want to graduate, because those feelings of wanting to help broadly will go with them.
It's interesting. One of the statistics about compassion in medical school is that it goes down through medical school, right?
Yeah.
People come in with a certain level of compassion, a certain idealism, and so forth, and some of that kind of gets beaten out of them
Sadly,
as they go through.
Right.
But I think, and some of that is healthy, right?
Yeah.
Because if you're overly compassionate,
Right.
it's going to be tough for you to make the right decision a lot of times.
Mm-hmm.
But I think that for whatever reason, we seem to have a pretty good mix.
We do.
Right?
We do.
And
strike a good balance.
Yeah. But it's just so important. So, so we've got a two-part question here. The second part of it is going to say future of medicine, right?
Okay.
What you think are where we're going with this. But the other one is, how do we help? And the we could be anybody, right? It could be people in healthcare. It could be just anybody.
Yeah.
How can we help with, and we have two intermingled stories, right? The dance is still going on.
Yeah.
How can we help with the opening of perspective, and how can we help with those individuals who have autism spectrum disorder?
Sure. So I think on one hand, speaking about healthcare and futures in healthcare, I think investing a little bit of time and interest in individuals, like what happened in my story, right? Investing a little bit of time in somebody can pay big dividends, right? It can lead them to things they didn't think were possible. So being open and available to do that, right? And that requires some degree of selflessness, right? Because it takes a little bit of time. And it doesn't have to be a lot of time, but being aware of what your comments and your encouragement can do and giving those, right? That can make a big difference. On the side of autism or patients with neurodiversity, again, encouragement, right? Encouragement of hey, this isn't the end, right? This is something that has its own set of issues. Let's work on them. There's hope there. There's things that we can do. We can help, right? Don't give up, because you don't know where you're going to be able to end up, right? And so that information to both groups, right? Keep working, keep pushing through, and having support along the way, because those are hard roads, will get them further, right? Either the group. So I think it's incumbent upon us, where we find ourselves individually, to be that support and to give that help.
That piece of it, I think one of the things that's really interesting to me about that is if we, and I don't know if this is an appropriate way to think about it, but we know autism spectrum disorder, right?
Mm-hmm.
It's a spectrum.
Mm-hmm.
But that's when you kind of narrow down and seeing those individuals that are on that spectrum.
Right.
But that spectrum is part of the whole spectrum.
Absolutely.
Right?
Oh, yeah.
And so if we think of ourselves, all of us are someplace
Somewhere.
on that spectrum.
Right. Absolutely.
Right?
Absolutely.
And so thinking about it in a us versus them or that
Right.
kind of thing, it just doesn't help any of us.
No. No, you're absolutely right.
And so, and exactly to your point,
Mm-hmm.
if we think about the, we're all on the spectrum, the big spectrum.
Yeah. Yeah.
So then how can we reach out to those individuals,
Yeah.
regardless of their situation, to spend an extra moment? I think about how many opportunities we have to do that. Somebody's at a cash register or somebody's giving directions.
Yeah.
Do they point to something or do they walk you over? Right, to the
Right.
place. Do
Yeah.
they make eye contact? Do they say thank you? There are little things a lot of times that make a big difference.
100%.
And I don't know, it would be really interesting to go back to your pediatrician and say, did you know that you were making this kind of a difference?
Right.
I'm guessing he'd say no.
I'm guessing no. Yeah, I'm guessing no. Yeah.
Because I think, and I think you do the same thing. There are people that are sitting in that pipeline program that are listening to you that you may never see again in your life, and you made a significant impact on them.
Yeah.
And I think we all have these opportunities if we take them.
If we take them. Mm-hmm. Yeah.
Yeah. And then the other side, the diversity side of it, that spectrum that we talked about, the spectrum.
Yeah.
Then you embrace, the people who are on it with you.
Right.
And you're able to do this.
Yeah.
So let me, I'm going to change gears a little bit.
Sure.
We've been talking about your story, your hero's journey. And so what is your North Star? Like, what is it, the thing that you see and that is immovable for you?
Yeah, sure. So and I was actually thinking about that as you were talking a second ago. So I would say that my North Star is two things. So I think it's my faith and I think it's my family. And related to my faith, I think one of the things that is my North Star is in my religion what we refer to as the second great commandment, right? Love your neighbor as yourself. And I think that's it, is you see people as your neighbor. Doesn't matter what they look like, where they're from, how they think. If you see them all as part of your neighborhood, then I think it's easier, right?
Yeah.
It's easier to take opportunities to help and to be kind. And those little things make a difference. So that's one of the things that motivates me, right? To recognize that I'm in the same boat with everybody else, right? And there's going to be times where I have the opportunity to share and to help and to give, and there's going to be times where I need that help and that sharing and that giving. And so if we're going to make it better, I think all of us have to play a part in that instead of seeing our differences and focusing on, you don't think like me, you don't look like me, and because of that, or you don't even agree with me, then you're out.
So I want to get to part number 2 in a second, but what you just said, when somebody is different, we have a choice of either to say, I'm going to push you away because you're different, or I'm going to bring you in because I want to learn about how we're different.
Absolutely.
Right.
Absolutely.
And it's so, and that's a choice that we have, right? And wouldn't it be wonderful if we made the choice of bringing people in more often?
Yeah, we'd be in a much better situation nationwide.
Yeah.
Yeah.
And family.
And family. Yeah, family's big. There's a quote I like that the things that matter most are the things that last the longest. And family lasts, right? And so that's taking the time to develop that base is really important, because when you have a good base or good foundation, you can withstand a lot of stuff, right? It's not going to shake you. So that the development of that, the time that's required to do that, I think is really important and totally worthwhile.
It gets back to the idea of creating moments, right? And taking just a little bit extra time to connect with people.
Right.
Yeah.
Absolutely. I wish, in my journey in life so far, medical school was hard, Residency was hard. Fellowship was not as hard, but all of it time consuming.
Mm-hmm.
And I think I look back now and I think I would tell myself, enjoy the moment, take the time, make those moments when you have them, and stop thinking about, when I have time, or when something is done, then I'll enjoy this or that or whatever. Yeah, I think it's really important to just enjoy.
I had someone in the introduction to graduate school, like an orientation, and she said, during this time in your life, you're going to be underpaid, overworked, and probably happier than you'll ever be. And I was like, what?
What? Yeah.
And it's right.
Yeah.
Not because of the overwork or underpaid,
Right.
but the connections.
Yeah.
Right, the connections that you made, and that's really where so much of the joy comes in.
Absolutely. And when I say family, there's blood family, right? But then there's your neighbor family,
right?
And I think you can develop just as strong and worthwhile bonds with them as you can with your own family.
Yeah, absolutely.
And all of it brings joy.
Well, you just had an excellent segue into the last question.
Okay.
Moments of joy for you.
Sure.
I know you got a whole slew of kids, so I'm only going to give you two moments of joy for the kids.
Okay.
But outside of that, or in addition to that. So you got two with the kids, and let's hear 3 or 4
some
others. Yeah.
Okay. So I would say one is when my kids are together, right? And when they were younger, when I was, again, going through my educational process, it wasn't as joyful as it could have been, or as it probably was, and I just didn't recognize it. Right? I was too stressed out. But seeing them together now is really neat. We last year we were able to do a family vacation, everybody together, and that was great. I really enjoyed that. There were moments of that where I saw all of them together, and that was joy.
Where did you go?
We went to Cancun, just south of Cancun, by Akumal.
Nice.
Yeah,
very
fun.
nice. 5 kids?
7.
7. Okay, snuck a couple in there.
Yeah,
That's the last time I looked. Yeah.
And then I'd say another one was I have 2 grandkids now. And so grandkids are a whole nother level of joy. And so spending time with them is fantastic. Not very long ago, maybe a couple weeks ago, my grandson, who's sometimes a little grouchy, they were leaving, and he told his mom something along the lines of, I want to stay with Pops. That's what they call me, is Pops. And that was like, yeah, I've made it. I've arrived. Yeah, that was great.
How old are the grandkids?
4 and 2.
Nice.
Yeah.
Very nice.
It was great. 4 and 3, actually, it's 3 now. Yeah.
Other moments of joy?
So professionally, I think my moments of joy are when I'm talking to families and we cross that line of I don't want to know to I understand, and I know that I can help. I know that there's hope now. That's really fulfilling for me. There's a lot of joy there in just watching them cross that and know, like, okay, they're going to be okay, right? It's going to be all right. Other moments, are just going back to my faith, is when I have the opportunity to help somebody, right? When I have the opportunity to provide support or to just listen, to see them feel better simply because I showed love or interest in them. That's great. That feels good, right? Like it should.
It's interesting. On this podcast, we have this question about moments of joy.
Yeah.
And I think this is true. Almost everybody talks about graduating medical school, or winning an award, or those things. Yeah. It's understandable, right?
Sure,
of course. But the joy of contribution that you're talking about, when you look at the science of happiness, right? I don't want to be too clinical about this, but when you look at the science of happiness, giving away, right, and contributing to others becomes the longest lasting happiness.
Absolutely.
And as much as I know that from the science of it, listening to you talk about it, wow.
What's the truth? Yeah.
So thank you very much.
Thank you. Well, you bet.
Grazie mille.
Grazie.
I hope you enjoyed the podcast and you received the warm welcome that Dr. Gaspar de Alba gives to everyone. Thanks for listening. As always, we're grateful for your time and attention. If you enjoyed the episode, please check out our other podcasts on Spotify and Apple, and don't forget to like, subscribe, and share with those you care about. Thank you so much for listening.